Hi, everyone. Thank you for joining us today. I'm going to give folks just a minute to join this webinar, and then we will get started. Hi, everyone. Welcome to today's webinar on ethical and legal considerations for client consent to share HIV data. My name is Dori Molizanov. I am our host for today. I'm from NASDAD. I'm a senior manager on our health systems integration team, and I'm also joined by Amy Kilday, a consultant with NASDAD. And we also have a few speakers who I will introduce in a moment. So just to discuss what we'll talk about, to go over what we'll talk about today, I think many of you may have attended our last webinar at the end of July, where we did a pretty deep dive into a few important legal frameworks that relate to the data privacy and client patient privacy patient data privacy considerations that we know are top of mind for everyone in our work right now. Today, we're going to start with an overview. Amy will walk us through an overview of some of those legal frameworks. If you didn't have an opportunity to attend our last webinar, that's okay. You'll still be able to follow along with today's discussion. But I do recommend checking out the recording and the links and the slides for that presentation. If you're interested in learning more about some of these legal issues. After our overview of the legal frameworks that we're going to be kind of thinking within today, we will have 3 exciting speakers lined up who will offer perspectives from health departments and providers. And then we'll close with discussion and questions. Feel free to drop any questions for our speakers through the Q&A feature in the Zoom. We'll address them towards the end of the session. If there's a particular speaker that you'd like to direct your question to, please, feel free to note that. Otherwise, I will deduce who I think it might have been directed to. But if there's a specific person you'd like to ask the question of, please go ahead and note that when you leave your question. Before we get started, I'd just like to introduce our speakers. We're very excited to have 3 excellent speaker/panelists join us today. Our first speaker will be Adrian Guzman, Director of Policy and External Affairs at the Bureau of Hepatitis, HIV, and Sexually Transmitted Infections at the New York City Health Department. Just quite a mouthful. Adrian, sorry, probably stumbled on it for a little bit there. Adrian is going to highlight for us how state and local health departments can employ a data-driven approach to ending the HIV epidemic while ensuring and protecting individual privacy. Our second speaker will be Sarah Badley, Director of Compliance at Fenway Community Health Center. Sarah will share how Fenway Health balances public health and healthcare services with patient privacy. And we will also hear from Kat Ross, Associate Director of Social Services for Ryan White Programs at Howard Brown Health. Kat will share how Howard Brown Health approaches notice and consent policies for sharing client data. So welcome, everybody. We're really looking forward to all the great content that we have today. And again, questions in the chat, feel free to drop them at any time and we'll address them later. Also, I did forget to say, but this presentation will be recorded and slides and a recording will go out to folks soon after this presentation's over. So with that, I will pass it off to Amy to get us started.
Terrific. Thanks, Dori. And hi, everyone. So I'm very much the warm-up act to it. I think will be super interesting perspectives from our 3 speakers. But as Dori said, I'm going to sort of set the stage, Some of this is going to be review from NASDAD webinars past, including the one in July that some of you may have participated in. But we want to sort of set the legal stage for what are some of the legal federal and state frameworks that are going to govern our conversation about what type of client consent is required to share HIV-related data. So next slide. So the first thing, and you may have seen this slide before because we at NASDAD really like to frame the conversation this way. When we talk about consent, we've got sort of two different pathways for consent. One is the consent to treatment. And in the cases that we're talking about today, we're talking about the consent to the HIV test, right? And that consent is governed by a host of laws that in this country where you need to consent for any type of medical intervention, including HIV testing. Now, states approach the HIV testing a little bit differently with opt-in or opt-out testing, but at the heart of any sort of the opt-in or opt-out testing policy or law is that you are getting consent for that test in some way. Okay, so that's our sort of first bucket. The bucket that we are focused on, because this is part of a 2-webinar mini series on data privacy and confidentiality, we are focused on the second bucket of consent to share HIV data. So it's not necessarily the consent for the test. Sometimes the legal and ethical considerations intersect, and we're going to hear from one of our speakers about how that happens. But we are really focused on the consent to share data. And that's going to be governed by, again, a host of another federal and/or state laws. So next slide. So last time we did an overview of the sort of the trifecta of HIPAA, state HIV and communicable disease confidentiality laws, and 42 CFR Part 2, to really talk about what are the legal requirements when it comes to protecting HIV-related data. So we'll start with HIPAA. That's the kind of the big federal law that governs health-related data. And we have this sort of flow chart. So if we think about HIPAA, and we'll sort of play this out on the no side, but on the yes side, if you think first, is the entity a HIPAA covered entity? And as Dory provided the overview last time, HIPAA covered entities are specified in statute and in rule. They are providers, health plans, and healthcare clearinghouses. This is also going to include labs. So it's basically providers that have electronic medical records, or they're holding your medical record. So if the provider is a HIPAA covered entity, so if the answer to that question is yes, and there is protected health information at play, so that's going to be like any part of your medical record, including HIV test that's attached to a person, a name, an address, and other identifying information, then there needs to be authorization. So a patient has to authorize sharing of that information unless there's an exception, right? So this is the flow chart. This is sort of like the structure of HIPAA. Patient consent is required when a HIPAA covered entity needs or wants to share a piece of protected health information unless there is an exception. So next slide, and I think we might we're going to do a poll to see from you all out there, and we'll go over in this more detail. So if you answer I don't know, don't worry, we're gonna demystify it a bit. But for folks out there, many of you are in health departments or other providers. Is the program that you work for a HIPAA covered entity? And we'll give folks another 20 seconds or so to pick a choice. And again, if you don't know, don't worry about it, because that's part of the webinar. Okay, so we'll end the poll. We've got a real mix, which is always good to see. We've got some people who are part of a HIPAA covered entity, some people who are decidedly not, and then we've got several people who do not know. So let's go to the next slide. So health departments, HIPAA covered or not. And for those of you who said don't know, health departments are a hard animal to really categorize in this space, because some health departments are and some are not. And some health department programs HIV programs within a health department are HIPAA covered and some are not. So if you said, I don't know, it's because it's confusing. And basically how you figure it out is that if the health department is performing functions that make it a covered entity, or meets the definition of the covered entity, they have to comply with the HIPAA rule. And so that could be, right, if you are at a state or local health department that's providing direct services, you're acting as a provider, right? So you're a HIPAA covered entity. Medicaid programs, so those are within a state agency, but those are covered entities. They're acting in this case as a health plan. And many health departments are betwixt and between, right? They are hybrid, meaning some functions are covered by HIPAA. And so if you work in that entity that is providing, is holding itself out as a HIPAA provider functions, you're going to have to comply with HIPAA. And then some parts of the health department are not. They might be, your surveillance program often is not HIPAA covered. You aren't providing any of the functions that make it a covered entity. So this is difficult. This is not something you need to figure out by yourself. Your legal counsel at your health department will know the answer to this. They are a good resource to figure it out, but just know it's complicated. It depends on the state. And even within your health department, which program you work for may or may not be covered by the HIPAA requirements. So next slide. So then we have the next layer, right, are all of the providers out there that are often in contract with state and local health departments to provide a range of HIV services, including testing, care, and treatment. And a similar sort of test kind of applies to them. In most cases, they're going to meet the definition of a HIPAA covered provider, right? A provider is a provider of medical or health services who furnishes bills or is paid for healthcare in the normal course of business, right? That is a very broad definition that's going to apply to the vast majority of HIV providers out there. And then the entities that probably are not going to be covered by HIPAA are going to be your smaller community-based organizations that are offering non-clinical support services. So they are not medical or health providers. They are offering the ancillary non-medical, non-clinical support services. This is important because it matters sort of if you're intending to share data, for instance, with a community-based organization for a data to care program, it matters that that community-based organization is covered by HIPAA or not. So the landscape and the way that HIPAA applies is going to vary across HIV programs within health departments, and then even across the providers who are contracted with health departments. So next slide. So how does this all kind of factor into our topic of today, which is consent to share data for in what we're talking about now for HIPAA covered entities. So HIPAA, our federal law and specific privacy rule that governs health-related information sharing, is actually quite specific and explicit about the requirements for a patient to provide consent for an entity, a covered entity, to share their protected health information. So their health data that connects their data to them, right? So the rule under HIPAA and our sort of general assumption is that you have to get consent, usually in writing, to share that information unless there's an exception. And the exceptions that we talked in detail about last time were for treatment and payment. And we'll talk about how that plays out in some of the providers that are going to talk to us a little bit later on in this webinar. And then for public health purposes. And for those purposes, that like big glaring one is for reporting of communicable diseases. So even if your health department, or rather, if you are a HIPAA covered provider, and that, HIPAA requires you to get consent before you share data, there's an exception to that. You can share an HIV test result that is connected to a person's name and identifying information with a health department for reporting of communicable diseases. That is a public health exception to HIPAA, and you don't need consent for that. So next slide. So the authorization then to share data under HIPAA, it has all of these kind of attributes. So if you are a HIPAA covered entity and there's not an exception, so you need to get patient consent in order to share their information, then the consent form that you need to give to that patient has to be in plain language. It's got to be specific. It's got to be identifying the person disclosing and receiving information. You've got to have the purpose on there. There's got to be an expiration date. And the individual has to have the right to revoke that authorization. So this is really very much a patient-centered, patient autonomy, safety protection to make sure that the person whose data is being shared is authorizing the long and short of to whom it will be shared and how it will be shared. So next slide. And so we kind of go back to our flow chart because we've been in the land of assuming a HIPAA covered entity, right? And that's when we're in the land of HIPAA. And so we look at, so we know HIPAA applies, and then we look at, does an exception apply? If an exception doesn't apply, we have to use that authorization with all of those bullet points that we just talked about. But as we know, and as many of you said, because you just filled out that poll, you are not working for an entity that is HIPAA covered. We go to the no flow chart, right? So you are working for a health department or arm of the health department that is not covered by HIPAA. So HIPAA now, it doesn't apply. It does not apply to the data sharing. But what does apply? It's not like you don't exist in a regulatory vacuum. We just look at, okay, HIPAA doesn't apply. What does? And there you're going to look to your state privacy and confidentiality law. And that is going to apply no matter what. It does not supersede HIPAA, but it adds often extra protections on top of HIPAA. But if you're not a HIPAA covered entity, your state confidentiality laws will likely apply to you. And this is the case for instance, state HIV surveillance data. There is often a state HIV or communicable disease law that applies to the privacy protections of that data. So next slide. And those confidentiality laws, again, as I said, they often apply to both HIPAA and non-HIPAA covered entities. They're adding protections onto HIPAA, right? So they're not supplanting it. They're add-ons to HIPAA. So if you're a HIPAA covered entity, a state confidentiality law does not get you out of complying with HIPAA. You have to comply with both, but they also apply to non-HIPAA covered entities. So like the surveillance programs that I was just mentioning. They generally require consent for sharing of personally identifiable data. So it's the same kind of like central premise as HIPAA. We start with the idea that you can't share data without somebody's consent. And then we add exceptions to the rule, right? It's the same kind of the way that the laws are set up are very similar. And usually the exceptions are fairly broad. So even for non-HIPAA entities who are governed by state HIV or communicable disease confidentiality laws, they can't share identifiable data except when they're making surveillance case reports. In some cases, there are explicit or at least assumed exceptions for linkage and retention or data to care programs. Responding to a public health emergency is usually in there, and it's somewhat vague as to what constitutes a public health emergency. But those confidentiality laws, they may have more stringent protections for HIV data than HIPAA does. So next slide. So for instance, and I won't go in too much detail on this, the state HIV data release form, some laws are very specific on not just the HIV specific requirements for sharing data that are, again, are layered on top of HIPAA, but they also provide specifics of what has to be in a HIV specific data disclosure authorization form. So California and New York are two states that require written consent for a provider to disclose in California an HIV test result, or in New York an even broader set of information, HIV related information. And then that's just a screenshot from New York's form below, for example, of how this plays out, of how an actual consent would be obtained from a client to share their HIV related information. Now, again, this is on top of HIPAA because the state law is even more protective of HIV information than HIPAA is. And next slide. So the consent policies are going to vary, and we actually have great speakers who are going to take up very soon to talk about how these processes and policies vary. You might see variation even within the same jurisdiction, across Ryan White parts, for instance. So you might have like a statewide floor, right? But then you're going to have variation in terms of the length of consent. that the data release is valid, for instance, the specific providers that are authorized to share information. Some providers include notices that HIV testing and other infectious disease testing information is going to be sent to a health department. Now, remember, that's outside of usually state confidentiality law and HIPAA requirements, right? That falls squarely into our exception. You do not need consent to share somebody's HIV test result with a health department for communicable disease reporting purposes. But some entities, some providers decide that they are going to give notice anyway. They don't have to, but they decide to do that anyway. And we're going to hear from our speakers about why some providers might decide to do that. So this is where you don't have to, but should you? It's the kind of line between legal requirements and then beyond legal requirements, what are sort of the ethical and mission-based priorities that would guide action. So next slide. And then I think this is the final slide, and then we'll turn it over to our or actually no, there's one more slide, and then we'll turn it over to our speakers. But this is just kind of like how all the questions and the different the different variations that this could take. So you start with your person, right, who's getting care at a clinic, and let's see they're getting HIV testing. So they might have a HIPAA consent, they might have a specific HIV consent to share data, and they might have a notice that their HIV testing information will be sent to a health department. So this can start to add up from a client perspective of like a lot of information about what the clinic is authorized to do with that person's information. And I add that as a like, not good, not bad, just so we should think about that. There are pros and cons of that amount of information at the point of care. And then, we have consent is necessary to share information with providers outside of the clinic. And no consent for the information to the health department. And next slide. And then finally, just like a quick note, because we covered 42 CFR Part 2 last time, this is a kind of a more specific set of protections for substance use data that is held by Part 2 substance use providers. So those providers have to get specific consent for release of substance use information, even for uses that would be exceptions under HIPAA. And we will not go into that. We could spend a whole series of webinars just talking about 42 CFR Part 2. My point that I want to leave you with is that substance use data is often governed by a different and more stringent set of rules and regulations, and sometimes laws, about the circumstances under which that data can be shared and what type of consent. And the reasons for that are apparent, right? Like, and much like HIV, it is sensitive data. There's a lot of stigma attached to it, and it can be used for discriminatory purposes. So there are laws and policies and regulations that put more autonomy on the patient to decide when and how and to whom that data gets shared. So with that gives you your like haiku run through of the legal frameworks. And I think I'll turn it back to Dory to kick off our speakers.
Hey, thank you, Amy. We will now turn to our speakers. So our first speaker for today will be Adrian Guzman from the New York City Health Department. Again, remind folks about what we're here, what everyone's talking about today. Adrian is coming here from the New York City Health Department and will be sharing state and local health department perspective on balancing data-driven practices with individual privacy. Welcome, Adrian.
Great, thank you. You can hear me, right? You can hear me?
We can hear you, Adrian.
Oh, great, thank you. Okay, great.
Yes.
Thanks so much for having me. As mentioned, I'll talk a bit about New York State and New York City practices. HIV laws and policies are largely matters of state purview in New York. But so while I'm speaking on behalf of the New York City Health Department, most of what I'll be describing stem and flow from our state public health law and state sanitary code. Next slide. So as mentioned, our New York State Public Health Law Article 27F governs the confidentiality and disclosure of HIV-related information across the state, with regulations implementing the laws in Part 63 of Title 10 of our New York Code of Rules and Regulations. Next slide. So I won't bore you with the ins and outs of all of those provisions, but I did want to pull out three definitions because I think we're a bit unique compared to some states with how we define some of these terms. So Article 27F, which is our HIV section of our public health law, protects the confidentiality of HIV related information about protected individuals and their contacts. So confidential HIV related information is a pretty expansive term. It means, quote, any information in the possession of a person who provides health or social services or who obtains information pursuant to a release of HIV related information concerning a number of things. That information could concern whether an individual has had an HIV test, has HIV or HIV related illness or AIDS, or really any information which identifies or reasonably could identify someone as having one or more of such conditions. So it's a pretty expansive definition. A lot falls under that definition, which strengthens our confidentiality protections across the state. So yeah, protected individual, a person who's had an HIV test or has been diagnosed, and a contact is an identified spouse or sex partner of the protected individual, a person identified as having shared drug use equipment with the protected individual, a person who the protected individual may have exposed to HIV under circumstances that present a risk of HIV transmission. So it's a pretty strong framework in terms of protecting confidentiality of HIV related information. So I just wanted to set that foundation to sort of give you a sense of the confines within which we're working. Next slide. So Amy touched on part of our consent form, although her font looked so antique, so it might have been a previous version, but it's the same content. This is the New York State Department of Health Form 2557. It's our authorization for release of health information and confidential HIV related information. So in that middle section there, you can see the three boxes to check. That's what Amy highlighted. And you can see on the right-hand side, I just pulled some of the text at the top of the form. It authorizes the release of health information, including HIV-related information. And then the paragraph following that sets forth different scenarios in which the information may be released. This is everything from healthcare providers caring for the patient or their child who may have been exposed to HIV. The second one's a big one, health officials when required by law. I mean, maddeningly vague language there, but understandably vague language there. Of course, insurers to permit payment, people involved in foster care or adoption, correctional, probation, parole staff, and so on and so forth. These are the types of exceptions that Amy mentioned during their presentation. Nothing unique here, but it is listed explicitly in, I think it's the second paragraph on the required release form for HIV related information in New York State. Next slide. We also have a separate form. This is similar, but this is an authorization for the release of substance use, mental health, and HIV related information. Given the sensitivity of information related to substance use and mental health services and treatment, this form was created to facilitate sharing of that information, not only within a facility where different providers handle these issues separately, but to facilitate the sharing of this information between facilities or between providers that are caring for the same patient, all with the end goal of allowing for coordinated and comprehensive care and treatment. So the form can be used in place of the previous form, but it's not intended to replace it. Next slide. So with that foundation, fast forward to 2013, 2014, New York State Department of Health convened a series of work groups and comprised of providers and advocates and people with HIV and people affected by HIV, which would eventually lead to the work group that issued the first ever jurisdictional plan to end HIV in the US. So in 2014, we released the New York State Blueprint to End the Epidemic. Technically, Governor Cuomo released it, but I say that because it was a government sanctioned document that listed a set of recommendations to achieve our ending the epidemic goals. I mean, nothing new here. Everybody knows what ending the epidemic means, especially now with our ending the HIV epidemic in the US initiative. But this was pretty groundbreaking at the time. And I bring this up because there were specific recommendations in the blueprint addressing data sharing. One of the blueprint recommendations, quote, recommended, quote, using client level data to identify and assist patients lost to care or not virally suppressed. And I am not mincing words when I say that this was a long, drawn out process where every word in the blueprint was looked over and examined and decided upon. This was a really community-driven process. So this was identified as a real need. So pursuant to that recommendation, in 2014, the governor signed into law legislation that expanded HIV data sharing from health departments to healthcare providers for the purpose of linkage to and ongoing engagement in care. So as of 2014, health departments could share HIV data with healthcare providers. These are clinical, medical providers. And in terms of the type of information, this was general information about care status, information about patient relocation, out of state or out of the region, and also reports of death and dates and so forth. Now, in 2017, we expanded that to include the ability for health departments to share that type of data with not only healthcare providers, but care coordinators for the same purpose. Now, I won't read all that tiny text at the bottom, but there was a very specific definition of care coordinators that was decided on. A lot of back and forth. A lot of these were regulatory amendments. So there was a period of public comment where people could weigh in on this. But essentially, a care coordinator refers to the action of managing, referring to, locating, coordinating, monitoring healthcare services for that individual, and to assure that all medically necessary healthcare services are made available to and are effectively used by the individual. And I just want to flag one thing. You may be familiar with RIOs, Regional Health Information Organizations. So throughout this whole process, it was decided upon that RIOs or providers affiliated with a RIO are characterized as care coordination entities for the purpose of this data sharing expansion. So that's where we are in terms of data sharing. Next slide. And lastly, I just want to highlight some amazing work that my colleagues in our HIV care and treatment program have been pursuing with regard to really deconstructing and interrogating the idea of client consent and HIV related information. So it started with our data to suppression for Ryan White Part A behavioral health and housing programs. We launched this in 2021 with just 13 agencies, about double the number of agencies the following year. And this program utilizes consumer level reporting on viral suppression status to help behavioral health and housing program providers focus on outreach and follow-up for people who may have been lost to care or people who are just have an increased need for these services. What we do as a health department is we generate and we share reports with providers via a secure file transfer protocol every 6 months. We also provide quality improvement, check-ins, learning groups, facilitated discussions, all with the goal of helping the provider improve viral suppression rates and reduce disparities and just really engage the client in care and treatment so that they remain healthy and thrive. All throughout this process, we had an advisory board of consumers. They informed our program activities. And ultimately, a primary recommendation was that we need to strive for a deeper focus on data equity. So this is kind of touching on what Amy said, and Amy said it much more articulately than I can, but the idea of yes, our practice of sharing patients' HIV data with their HIV service providers is absolutely legal. It's lawful. It's within the confines of our New York State public health law. But does it align with the values or privacy expectations of people with HIV? So our goal was to explore that, to balance consumer privacy and health department goals. So in response, we launched DISCO, Developing Information Sharing Standards Through Community. This was designed to center community and consumer experiences in revising our data to suppression protocols using community feedback on these policies and standards. So on the next slide, you'll see just a couple of questions. These are animated, so you can just click through them. These are just a couple of questions that we asked ourselves, our consumers. Should data sharing be opt-out or opt-in? How should consumers be notified when their data are shared? What types of data and what level of detail are appropriate? One important question, how often should data sharing preferences be reviewed? And what are some ways to make these processes easier for consumers to understand? So we used a deliberative democracy model to explore this. And on the next slide and the last slide, you'll see that through one more, because the animation was weird. So through in-person informational panels, Q&As, small and large group sessions, all the DISCO participants worked towards a consensus on a series of proposed policy statements. So these are the topics that we sort of organized the conversations around: statements on informed consent, on the frequency of obtaining consent, the whole process of informed consent. We're also exploring informational videos on this, a website. How do we notify people of disclosure? And then there's the idea of a patient portal. So this is what we're working through, and we're working really closely with our consumers, our Ryan White Part A consumers, and the HIV community more broadly to ensure that we are approaching this not just within the confines of New York State public health law, but in a way that's ethical and that balances consumer privacy with our own ending the HIV epidemic goals. That's it.
Thank you, Adrian. We're going to continue going through our presenters. We're going to continue on to our next presenter, rather. But in the meantime, if folks have any questions for Adrian, please feel free to drop them into the Q&A, and we will address them. We'll address them later when we get to the Q&A portion. For now, we will just continue on through the presentation. Our next presenter is Sarah Badley from Fenway Health, who will share how Fenway balances public health and healthcare services with patient privacy. So Sarah, whenever you're ready.
Thank you. So we can start on the next slide. So Fenway Community Health Center has 3 main departments. The first is a federally qualified health center. We have a public health division that provides sexual health testing and outreach, HIV and AIDS outreach, and drug user health, including a clean needle exchange, and the Fenway Institute that conducts research and provides LGBTQIA+ healthcare education. Each of these divisions, as I'm sure you can imagine, has its own needs and limitations for data sharing, but as an organization, we really are committed to making decisions that center the needs and safety of our patients. We serve a population that's overwhelmingly LGBTQI+, and our patients come from all over to get care that's not readily available in their home states. And because of this vulnerability, we're committed to taking privacy very seriously and do what we can to start from a position of sharing less, asking for consent more, and allowing patients to opt out whenever it's possible. Now, we still do comply with our state laws and contracts to provide required data, but we do our best to use de-identified data as much as possible to protect patient identity. And our notice of privacy practices is robust, and we try to be very clear about what we share and why we share it. Next slide. I went too far. Should be on. competing interests. Sorry about that. So outside of legally required data sharing, we do our best to fully consider how and when we share patient-level data. This starts with our multidisciplinary team for decision-making, which includes medical and program staff, privacy staff, data, and IT. And as much as possible, we make case-specific decisions that take into account our responsibility to our patients and our responsibility for advancing research and resources. In cases where it is a can share as opposed to a must share, we take into consideration the benefit to our patient population as a whole if we do share data and the potential risks for the individuals involved before we decide whether or not to share. A couple of case-specific decisions we've made recently. In one example where we decided to share information, we have data sharing agreements with a couple of different city public safety offices for the purposes of a post-overdose support team. In this instance, we have city public safety offices that share, and we share with them, police and EMS data, so we can follow up with folks who have recently survived an overdose and link them to services. And this was an instance where we felt that our responsibility to our patients and to care for patients who are experiencing overdose and substance use overruled the interest in keeping all of our data private rather. In another instance where we decided not to share data, we received a request from our provider scheduling software company who wanted patient-level data for them to run through their algorithm to set provider schedules. We didn't think that this was a reasonable request for data because it wasn't clear why they would need such patient specifics outside of the generic time slot filled or not filled and type of visit. Now, we reassess when needed. So for example, if the scheduling software comes back with a compelling reason for us to share that data, we would consider that in the light of new information. But we do maintain our responsibility to our patients to maintain as much patient privacy as we possibly can. Next slide. So some of our ongoing challenges and concerns, we have really put that reassessment into practice. Fenway Health is almost 2 years into its use of Epic as its EMR, and we are constantly having to weigh and tweak the setup to be sure our patients receive the care they need in a timely and cohesive manner, but still have control over their medical information. So I'm not sure how many folks are familiar with Epic, but Epic has a feature called Care Everywhere. And Care Everywhere allows providers who are on Epic to see all encounters for Epic registered patients at Epic using facilities. So for example, if we have a Fenway Health patient using where their medical record is on Epic and they get care at Mass General Hospital, our providers and Mass General, who are both using Epic, can see those encounter level data. It shows up in the encounter list with a little swoopy E next to it. And you have the ability to open that and see the encounter level data without, it's under the care exception to HIPAA, but you can see it without like an extra level of request for that data. It's great for care continuity because it allows us to track our patients' care without delay, but it also means there's no delay for accessing records where there's a potential risk for patient privacy. It's also set up as an opt-out system. So all patients are automatically enrolled in Care Everywhere and have to actively opt out of sharing if they so choose. Now, for most of our patients, we've determined that this setup is satisfactory and we respond to individual patient requests to opt out. But certain diagnoses, including a diagnosis of substance use disorder or care for substance use disorder and HIV diagnosis, turns off fully the Care Everywhere sharing. Now, this is another situation where it's great for patient privacy because it completely blocks off that information and makes sure that that diagnosis is not widely spread, but also can create barriers for care continuity. So even 2 years in, we're still trying to find the right fit and the right balance for how and when to share this patient information. But we do what we can to stay rooted in our mission to serve our community and protect our patients in all of our decisions.
Great, thank you, Sarah. Any questions for Sarah can go in the Q&A. I see there's already at least one question in there for us to revisit later. Also, to the extent that you're concerned, you want to ask a question, but you want to ask it anonymously, you should be able to do that using the Q&A. So feel free to ask anonymously if that's more comfortable for you, but we encourage you to drop any questions that you have. And we will continue now. I'm going to turn off my screen share and we will hear from Kat Ross. Kat is the Associate Director of Social Services for Ryan White Programs at Howard Brown Health and is here to talk to us about how Howard Brown approaches notice and consent policies for sharing client data. So Kat, it's all yours.
Hi, y'all. Thank you for having me. So I come to this work, I've been in the associate director role for the last 2 years. Prior to that, I was in a program management role, but I've spent my whole career in Ryan White Services, starting as a case manager, more than 12 years ago now. So I approached this kind of from two factors. On the one side, I looked at Howard Brown internal documents and documents that our staff frequently interact with patients. So like the Illinois Department of Public Health, I'm out of Chicago, the documents for ADAP, for example. And then I also just asked some of my internal team questions. So I asked them questions like, how do you explain to patients that their information, like a positive HIV test, will automatically be shared? What feedback do you get from patients in these situations? Do you think our current consent forms and practices around notifying patients about their privacy rights are clear enough? Are there areas where patients seem confused, or what concerns have been brought up to you? And are there questions that you encounter from patients that you don't know how to answer? And then how do you approach data sharing conversations with more vulnerable populations who might have additional concerns about their privacy? And I got really to nerd out with a lot of different folks. We're also an FQHC, so I was able to talk to people from nursing, from prevention and outreach testing, from case managers, linkage to care, people who have had roles as MAs in the past, medical providers. So I got a lot of feedback from a lot of different parts. And it's funny that Sarah was talking about Care Everywhere. We also moved into Epic about 2 years ago, and have, the Care Everywhere opt-out was an interesting part of the discussion, in that, like, how are patients informed about Care Everywhere automatically sharing that information to other Epic participating providers? And then, how can we empower patients to make informed decisions about their data sharing and ensure that they understand the benefits of Care Everywhere and automated sharing as it goes to continuity of care, but also can have their questions answered about the potential risks that they perceive and make the decision that's best for them. And that kind of brought up for me too, going into the future, like if a patient opts out today, how can we, maybe as their medical needs change or we're making more specialty referrals, how can we approach that conversation with them in context of their healthcare changes without being coercive, to sort of reignite the conversation that perhaps continuity of care sharing might make more sense. I also looked at our release of information, which, is pretty basic, and I can share a copy of it, but essentially it has this, special section that looks at HIV status, behavioral health, substance use, these things that require the above and beyond release. And I started thinking about how does that de-identification, so if I'm the patient and I say, yes, you can share my complete health record and I'm living with HIV, but I don't approve of that special section. Well, if you refer me to a specialty provider, for example, is my problem list attached to that? Is my medication list attached to that? Are there things that might inadvertently disclose a patient's HIV status that, in practice, in theory of this release of information should be excluded, but in practice, in terms of what Epic allows or what the referral requires, may actually not be possible. So I know from kind of preparing for this as an administrator now, I see some opportunities to go in and have some internal conversations, really to empower my case management teams to have more meaningful conversations with patients and ensure that the consent that we're getting is truly informed consent and that they're able to navigate some of the case specific examples. So when I was going through IDPH paperwork, which is a much more, legally heavy consenting, I did sort of a practice of reading through and then trying to translate in plain language, so English to English, but complex legal writing to more conversational writing. So one of the recommendations that we could all take away, I noticed it with internal and external documents, is that they're written at a pretty high grade level, probably for the purpose of their legal soundness. But like, how do we empower case managers to actually have a conversation with patients about the meaning of this? On the one hand, you may have newly diagnosed folks who are overwhelmed by the, news of their diagnosis and are just signing the forms without really taking in what the forms say. Or on the other side, you may have people who have interacted with the system for a long time, long-term survivors, who know that they have to sign these documents in order to enroll in the program and access these benefits, and may not even really be reading them at all. And I strengthen my hypothesis on that, because there are some of these documents that have been live and in use by the program for over a year and have incomplete sentences, which leads me to believe that maybe patients aren't reading it and maybe staff aren't either. As an administrator internally, it makes me want to go and have a translation activity with case managers where we really sit down in groups and try to break down, what do these things say and what do they mean and how does it translate to what you can explain to the patient, versus this is kind of the spirit of this document, which I think can become practice. Let me just kind of look through my notes. I know we only have a few minutes left, so I kind of there was a really great example. Oh, sorry, go ahead.
We're great on time, actually. Sorry, I didn't mean to cut you off. So feel free to go ahead. This is scheduled until 4:15. So
beautiful. All right. So one of the things was about, complex language and immigration related fears and just sort of more vulnerable populations. A lot of folks mentioned that, older folks may have more concerns with care everywhere and the way that automated data sharing works, and may just have more questions. That some folks struggle with understanding the consent forms, especially when third parties are mentioned. So it can create confusion and fear, especially for patients who have concerns around immigration, or just particular concerns around information sharing between medical providers and government entities. So I think I see opportunity to really empower our case managers to understand the benefits of that information sharing, so that they can have more effective conversations with patients in the real world about how these legal documents and consents play out with their real information. So simplifying language, making sure that things are written in like a 6th grade level or below if possible. And one of the kind of recommendations I have for, community-based organizations is to maintain a good relationship and positive rapport with your health department. I have found that our health department, with the sort of advocacy of our lead agent, we were able to facilitate some change in the way that the documents were written. The example I can think of is when they introduced a partner services agreement for case management patients. The concern originally was just kind of, the way that it was written was very like consequential, like as if you, the client, don't participate in this and don't share your partners, there will be some consequence. And it was, it was a concern. We really didn't have the training to back it up. So I guess that's the other piece, is that case managers need to be trained to provide the services that they're expected to provide, whether that comes from the lead agent, from the state health department, or from organizations administration like at Howard Brown. Like, is this an internal training that we need to provide once we realize we're expected, not just our partner services and DIS team to take on this this work, but also for case managers to be able to handle those conversations. So we went to our lead agent with our concerns. They went to IDPH with the concerns, and through some back and forth and really with the participation of people like myself or case managers, clients, people from our cab, I through looking at these papers, this is the original. It's like very like legally heavy. And then the new version is very like, how does it play out in case? So it's very much written in plain language. How do these different partner services options like provider notification, contact notification, and dual notification, how do they play out in an example? And then instead of it being an agreement, like you have to sign this, or if I fail to do so, there will be these actions outlined above, versus the updated one that says, I acknowledge the following. My case manager provided me this information. I understand that participating in partner services is completely voluntary. I understand that what these activities include, and if I choose to participate, what notification methods are available to me. So it's the difference of an acknowledgement versus an agreement. It just gives a little bit more consent and less consequence. And I think it's beautiful how we were able to kind of transform this document from something that felt a little bit scary and that case managers were underprepared to facilitate with their patients, to having that really good rapport and collaboration with our state health department that actually transformed this document into something that I think makes patients more willing to participate in the partner services process and perhaps even request that service from their case manager. So yeah, ultimately all of this resulted in a very like rich discussion, somewhat philosophical, and really trying to balance, obviously we don't have the ability, or you could even make the argument of should we want to transform mandated public health data sharing? Probably not. It has a benefit, but how do we ensure that patients are properly notified, and that what the implications of that data sharing are really made clear, so that patients feel more confident interacting with these systems?
Great. Thank you. I tend to take your pause as an end.
Yeah, I'm looking through, and I think the only thing I could maybe just add is some of the practical solutions. So we were talking about, I was talking to my case managers about when they make referrals, and sometimes they'll have Ryan White case manager in their signature on their email. So changing, taking Ryan White out, or just being mindful of like, do patients understand that being a Ryan White patient by its name indicates your HIV status, and just being considerate about things like that may not seem like an overt disclosure, but in fact are.
Great, thank you, Kat. That concludes our speaker presentations for today. We do still have time for questions and discussion. We have this webinar scheduled for another 15 minutes. So we have one question so far from the audience, and then I'm actually going to turn to Amy to ask a question. So let's start with our question from the audience. This is a question for Adrian. Adrian, how many consumers were engaged in the feedback process, and how representative were they of people living with HIV?
The feedback process, which one? I guess going back to 2014, all of the different work groups that helped develop the blueprint, I guess would be a good place to start. I know that New York State Department of Health was very committed to ensuring that not only community members, but also representatives of organizations and providers and also government officials were representative of the HIV epidemic in New York State to the extent possible. So it was something that leadership was very committed to as far back as 2013, 2014, when we were developing the blueprint. And we've only gotten more and more committed since then to ensure that all of our community advisory bodies, our planning council, our prevention planning group, and various other consumer advisory bodies are that they mirror, and to the extent possible, our local epidemic. So yes.
Thank you. The person who asked the question did clarify that they were referring to the DISCO process.
Oh.
You can talk about that too. That was a great answer, and maybe we can also hear it now about the DISCO process.
I can speak generally that yes, it was certainly we were certainly committed to ensuring that the makeup of the DISCO participants did reflect the epidemic, particularly because we were talking about Ryan White Part A consumers and we were talking about housing and behavioral health programs. So we were drawing directly from Ryan White Part A consumers. And I can speak to having presented at one of those large group meetings that I mentioned for DISCO. I can tell you that these were a group that certainly represented our Ryan White Part A community partners, community members.
Great, thank you, Adrian.
But can I
And,
just say, it's a really good point though, because when we talk about community and soliciting and incorporating community feedback, we really have to be thoughtful about that, because I don't know about elsewhere, but in New York City, community is rather expansive, and the louder the voice, the more they'll be heard. And the people who are leading some of the advocacy aren't always representative of the current and local epidemic, or the current and local communities that are affected by HIV. So when we talk about this, we are very thoughtful in ensuring we're not just talking about the community, but really drilling down to what that means, and being thoughtful and meaningful when we talk about and work with community partners.
great, thank you, Adrian. Folks can take their time to continue thinking of questions, dropping them in the chat. And for now, Amy has a question for us.
Yeah, so I mean, thanks everybody for your presentations. I always learn a lot when I hear how others are sort of thinking about this, because it's really you know, it's a hard kind of balance. And so I was really struck, Kat, by what you talked about in terms of, and then did at Howard Brown, in terms of the balance between the ensuring patient autonomy and connecting that to trust in the agency and the process, but not overwhelming. And I'm wondering, Adrian and Sarah, if you might be able to talk a little bit about like where you all, from your perspective, see that balance. Like, when does patient information become too much? Like, when does the scale sort of tip, and it's not about autonomy at this point? You're either confusing or scaring somebody. And how do you like navigate that? And I think that's like particularly true when you're not talking about a legal requirement, like that bright lines, okay. It's the sort of the squishier, like, you're not legally required to, but like, what's in the best interest of like public health and individual consent. So just wondering like how you balance that, and like it boils down to like, how do you decide when it's too much notice, it's too much information, and like, where do you draw the line? And I don't know, Adrian, do you want to start, and then Sarah?
I mean, my answer is a full-throated, I don't know. I mean, I think that's the question, right? I mean, that's what we've been struggling with, and we're really committed to ensuring that as we struggle with it, we bring in the community to struggle with us, because these are questions that, as we, we're what, a decade into the first state legislative change that allowed the health department to share data with healthcare providers. We're about 5 years, 5, 6, 7 years out from expanding that to include care coordinators. And there are so many things to balance when considering the utility of those things, and considering how it's affected our HIV surveillance data. Have these shifts in the law, I mean, it's a sort of a legal epidemiological question. Have these shifts in the law resulted in any measurable change to our HIV surveillance data? Have we seen improvements in viral suppression? And can we tie those improvements to these expansions in HIV data sharing authority? And I think it's factoring in all of that and figuring that out. So that's what we're working on. And I think that's the first step, is convincing a health department leadership to allow us to ask these questions. It's and prioritizing this work, I think, is important as well.
Thanks for that, Adrian. And then Sarah, like from your perspective, and I guess like for how Fenway kind of structures its policies, and you know, and I do realize I'm asking like a like a sort of unanswerable question, but like I guess like has Fenway ever come up to a line and said, you know what? If we give patients that information in a consent or notice form, it is going to scare them. We're not doing that. Like have you sort of had to kind of grapple with like how and where you draw that line?
We definitely have had to kind of weigh that. Our medical records team, when they get a release of information, I think 40 or so percent of the time, they get an information release form that's not completely filled out because they come to the section where there has to be an affirmative consent to release certain types of data that do have those extra levels of protection, including HIV data, that it's just not filled out because patients don't know what to do with it. So we're required to have that consent and to have that very specific consent to release that data. But patients don't understand it, and it requires some hand-holding with patients to be able to explain those forms and how to fill them out to get exactly what they need. And that it's just having people who understand it be able to explain it to patients, because giving a written document isn't going to work for many people. And it's definitely a challenge to balance how much we can give in explaining in a written document and how much is just going to need to be conversations and relationship building.
That's super helpful.
To that point, to that exact point, I think further complicating this is the advent of molecular HIV surveillance and how this factors into consent. Are we expanding traditional consent to include the collection of molecular HIV surveillance? And also, are we able to explain MHS at the literacy levels that were discussed a few minutes ago? Are we trusting are we, or frankly, are we burdening social workers and caseworkers and care coordinators with explaining the implications of all of this? So we have to ask these questions, whether expanded uses of these genetic sequence data for quote prevention, if this reaches beyond like the traditional ethics frameworks that we've been working within. More unanswerable questions.
Kat, did you want to weigh in on that one? No pressure, just.
No, I think I agree that it's messy, and I really like what Adrian said about, you know, we invite the community in to struggle with us, where there's not a perfect answer, and any person deciding on that in a vacuum is sure to be wrong. So, you know, as much collaboration and discussion as we can have. I mean, this is a really exciting, I'm like really happy to be able to nerd out on this topic and really dig a little bit deeper into, you know, what is our practice, what's our habit, and what are we doing just because it's always been that way, or what are we avoiding because there is not a perfect answer, and there's not a one size fits all answer. What we all decide works for the majority may not work for some. And to kind of respond to like, is it a burden? Like, I think there's a lot of opportunity to ensure that that case managers, care coordinators, people providing direct services are empowered with the you know, the information that they need to support these conversations with patients. And that they have a curiosity for that information and how it actually works. Yeah, I think we have an opportunity to deepen the opportunity for consent.
You. We do have around 5 minutes left. No outstanding questions now. So if folks want to add any questions last minute, also if you'd like to unmute and say something or ask a question. I don't know if you can do it yourself, but if you raise your hand, I think I'll see it and I should be able to unmute you. Do any of our speakers or Amy have anything else to add while we give folks a couple last minutes to ask questions? Okay. In that case, I think we can give folks back 5 minutes of their time. I put my contact information in the chat. It was on this slide too, in case you missed it. Please don't hesitate to reach out to me if any questions come up for any of our presenters later on. You're thinking later this evening about all the great things you learned today, and another question comes to mind. Feel free to send it my way, and I'll make sure it gets to where it needs to be. And look out for slides and a recording for this webinar. And thank you so much for joining us today.
Thank you. Thank you for having me.
And yes, thank you so much to our speakers. My apologies. Thank you so much for joining us today, all.
Thank you.